Good afternoon, everyone, and welcome to another presentation, part of our Envisioning Equity, Addressing Inequities in Healthcare series. We're so glad that you were able to join us today. Before we begin, we want to let you know that we will be recording this presentation and can be viewed at a later time. Additionally, if you have any questions at any point in time or during the presentation, please feel free to add them into the Q&A chat box. Thank you again. Before we begin, we want to thank our partners, the Medical Humanities Program at Baylor University, the College of Arts and Sciences, the Center for Church and Community Impact, and the Diana R. Garland School of Social Work, as well as the Baylor University External Affairs. My name is Carla Bautista, and I'm currently a graduate intern at the Office of External Affairs. We focus in five main areas. Our focus is in five main areas: education, economic development, cultural wealth, city growth, and health. This series focuses on health and how we can better address and advance equity in our community. Today, we will be joined by Dr. Linda Murray, where she will be presenting a presentation titled Health Justice, Changing the Face of Healthcare, a conversation exploring the current state and problems of the US healthcare system, how the COVID-19 pandemic has further exacerbated the underlying inequality, and solutions to address and improve healthcare inequality. Dr. Murray received her medical degree at the Abraham Lincoln School of Medicine, University of Illinois, her Master of Public Health degree at the School of Public Health at the University of Illinois, and was a doctoral student in the Public Health PEW Health Policy Program at the University of Michigan School of Public Health. Dr. Murray has been a voice for social justice and health as a basic human right for over 50 years. She has spent her career serving the medically underserved, as well as an active member in a wide range of local and national organizations. Dr. Murray has held leadership roles in public health organizations such as the National Association of City and County Health Officers, Health Equity and Social Justice Team, and the National Executive Board of the American Public Health Association. Today, she serves as an honorary attending of Cook County Health and is an adjunct assistant professor at the University of Illinois School of Public Health. Our moderators today are Dr. Stephanie Body, Assistant Professor of Church and Community Ministries at the Diana R. Garland School of Social Work at Baylor University, as well as Dr. Lauren Barron, inaugural Michael E. DeBakey, Selma DeBakey, and Lois DeBakey Chair for Medical Humanities, Clinical Professor and Director here at Baylor University. Before we begin, we want to lay the foundation with these three terms. So what is equity? Before we talk about equity, we want to talk about diversity and inclusion. Diversity is a presence of differences that may include race, gender, religion, sexual orientation, ethnicity, nationality, socioeconomic status, language, disability, age, religious commitment, or political perspective. Inclusion. Inclusion is an outcome to ensure those that are diverse actually feel and or are welcomed. Inclusion outcomes are met when you, your institution, and your program are truly inviting to all. To the degree to which diverse individuals are able to participate fully in the decision-making processes and development opportunities within an organization or group. Equity. This includes elimination of policies, practices, attitudes, and cultural messages that reinforce differential outcomes by race or fail to eliminate them. Equity is promoting justice, impartiality, and fairness within the procedures, processes, and distribution of resources by institutions or systems. Equity is a condition that would be achieved if one's racial identity no longer predicted, in a statistical sense, how one fares. When we use the term, we are thinking about racial equity as one part of racial justice. And thus, we also include work to address root causes of inequities, not just their manifestation. Tackling equity issues requires an understanding of the root causes of outcome disparities within our society. It is through this series that we hope to gain a better understanding of the root causes of disparities within our system and discuss possible solutions for eliminating them. And with that, we welcome Dr. Murray.
Well, good afternoon, everybody. I'm so glad to join all of you here. And let me get my slides up. I want people to know that for these slides, the organizers have a PDF of these slides, and they'll be distributing them later. So hopefully you'll find them useful. Um, I'm starting off here with Brother Malcolm because this quote of his, "Thinking is dangerous," is one of my favorite quotes. And what I would like you to do with me as we talk this afternoon and have a discussion after my presentation is think about what you think makes people well or what makes people sick, and sort of back up and really be willing to ask different kind of questions than we often ask about these issues. So whether you're learning in nursing school, or you're a social worker, or you're a physician, this question, why are some people healthy and others not? That's the fundamental question that we ask both in clinical health, but also in societal health. Why are some countries happy and others unhappy? Why are some countries at peace and others at war? These young kids in this photo are children from Flint who are out there demonstrating, hoping for good water. So in science, any kind of science, but in science, when we ask these questions and we try to find out the answers, we do it based on a framework of how we think things work. And I had this up here because this is the Hippocratic framework. And this has been used in Western medicine. You can see from 450 BC to 1858 AD. I'm going to tell you that you were probably raised on this model. I know, even though I was a medical student, I know I raised my son on this model. These are things like, well, Texas, you might not have this, but up here in the Midwest, don't go out in the wintertime, put on some boots, don't wear tennis shoes, you'll catch pneumonia, put on a scarf. We have all of these notions that we use on everyday activities that we think has something to do with health. Now, I'll be honest with you, whether you wear a scarf or not, even in the Chicago winter, it's not going to determine whether you get influenza or some other infectious disease. But nonetheless, these notions exist and they last a long time. The other thing that's in Malcolm's quote in that first slide is, how do we compare to other countries? So this is a report that came out a few years ago looking at the health of Americans compared to other rich countries, mostly European and Japanese. And let me just say here that throughout this slideshow, I'm going to be showing you some books that you can read. These aren't textbooks. These are books that I think fill in background information. If you haven't quite decided what career you want to pursue, some of these books may help you. And so I want to let you know that the National Academy of Science puts out a whole range of these reports. These are all their books, but they're free to anyone. You can just register and you can download a PDF of them. So you certainly could go look this up if you wanted to. So here's a graph. Let's look at it for a minute so we talk about what this is saying. It's going from 1980 to 2005, and it's saying, what are the chances this happens to be for men? What are the chances? What's the probability that a baby boy born in 1980 would live to be 50 years old, which now to me sounds like a very young person. My son is 50, but what are the chances that a newborn baby boy would live to be 50? And each one of these circles here is a country. Great Britain, France, Italy, Japan, they're here. The red dots is the United States of America. And so what is fascinating to me about this graph is if we look at this, just step back and look at it, one thing we can see is sort of over time between 1980 and 2005, and this has continued on since then, the likelihood that little boys will live to be age 50 has improved. That is to say, the sort of group of dots are getting higher and higher and higher, which is a good thing. The other thing that's remarkable in this slide is that where the United States sits compared to our peer countries has gotten worse. So in 1980, we were sort of in the lower half, but there were people below us. But look, starting in 1990 and 1995, there's only one country below us, and more recently, none of these countries are below us. So actually, our standing compared to other rich countries has gotten worse. Which should be concerning to anyone living in the United States. Here's another look. It's looking at life expectancy. This happens to be life expectancy from birth over time. And this is going from the 1970s. The dates are, you can see on that red line, to 2014. And you can see some of the different countries. And basically on the bottom axis, x-axis, is how much money we spend in healthcare. And then the y-axis is the life expectancy. But you can see here, every country on this graph, Greece, Chile, Korea, they are spending less money on medical care and they're living much longer. And we are by far an outlier. So we spend millions and trillions of dollars on medical care in this country. We don't cover everyone, so that there are many, many Americans that don't have health insurance. And our life expectancy and many other outcomes are worse. So something is going amiss here. So I'll say this bluntly and crudely. If you think that the United States of America has the best medical care system in the world, you're wrong. That doesn't mean that we don't have great institutions that do miraculous stuff. But if you look at it as a system, how many people in this country have an opportunity to use our medical care system? We're at the bottom of the barrel. We don't have universal coverage. So let's look at a problem. I kept this in Chicago, but it's a problem all over the country, and we'll talk about it. And then think about it in different ways. This is just a case study. In this case, we're looking at children that fall out of windows. I don't know how many of you are parents yet, but this is a concern. And hundreds of children, unfortunately, die every year in this country by falling out of windows. So this is a specific case that was seen where I used to work. This was a 3-year-old Mexican-American child that was brought to the emergency room. They had severe head injuries, and they had fallen out of a 3rd-floor window. At the time this occurred, the mother was home. The father was in the backyard and actually saw the child fall. The baby bed had been placed in front of the window because it was very hot. It was summertime. So we can't do this on Zoom, but so some of the questions that you ought to ask if you were a young nursing student or medical student is, other than taking care of the head injuries, what else do you need to do for this kind of case? Should you notify protective services? Why did the injury occur? Who's responsible for the injury? And what's our role as healthcare workers? So when we have a problem like this, it really depends on where you are. So if you don't know the family and you're suspicious about them, and you say to yourself, and especially if you don't have children, you say to yourself, well, what idiot lets their kid fall out the window? That's not always good. If it's your family, if it's your kid, and you feel like you're being a good parent, you don't ask that kind of question. So we do in healthcare what we call look at all of these cases. We look at the epidemiology of these falls. How many people fall out of windows? What's the characteristics? So this is giving you some national feeling about it. These are for children under the age of 15. This happens frequently. This is not that unusual. Children of color, minority children, are at the greatest risk. They fall out of windows more frequently, especially children between 0 and 4 years old. And they're overwhelmingly male. And again, if you don't have kids, you may not understand that, but little boys are different than little girls, and they do different stuff. So I'm not surprised that they're overwhelmingly male. This happens usually at home. And again, not so much in Texas, but in the Midwest and the Northeast, where we have winter and fall, this happens especially in the early spring and summer. This is a seasonal problem that we see. We don't see a lot of kids falling out of windows in January in Chicago. So this is a problem. And so one of the things that our health people did, our trauma surgeons, who unfortunately these children would present to, is they set up a program to try to help prevent this from happening. And they happened to go to a pre-baptismal class at one of our local churches, where the parishioners, in order to get their child baptized, they have to go to classes. And so one of the things that our trauma department was able to work out is that they would be part of the baptismal class teachings, and so they would teach the parents and the godparents to be how to child-proof a house, what you can do to decrease child injury. So this happens to be a young kid. Another big problem in Chicago, at least, and in Midwest, is children being burned by hot water in our hot water system. So this is a mechanism to try to keep track of that. So the parents are taught this kind of information, and obviously child falling was one of them. So what to do about this? How do you solve this kind of problem if it's mostly children of color, especially under 4, especially boys? Um, so here are 2 cities' approaches. In New York, they passed legislation requiring mandatory window guards. So think about it. Most people who don't own most poor people don't own their own homes. They're renting. They're not in charge of what goes on with the windows. So New York said, if you have an apartment and you're renting it, you have to have mandatory window guards. And they talked about how, so that it's not, so it becomes almost impossible to accidentally fall out of the window. Then they did something else, which is unusual in the United States. They actually enforced the legislation, which you could do with the guards they were using. You could walk along outside and see this building doesn't have guards, this building does. So they actually enforced the legislation and fined the landlords. And then they also did parental education around windows and falls and other things. After they did this, after they had legislation, they enforced the legislation and did parental education, they had a 96% decrease in their window falls. In Chicago, we didn't have legislation. The Children's Hospital and our Cook County Trauma Unit worked together. We did education. We didn't see a decrease in our falls. Which brings me to how we think about health problems. Do we think the problem is that that mother was not keeping an eye on that child? Like I said, if you're not a mother, you may believe that, but children can get into trouble in a nanosecond. And forget about what if you have 2 or 3 kids. Do you think that it's really that the parents weren't aware that a fall from the 3rd floor window was dangerous? Absolutely not. So it's important to remember that while you want to do education, focusing to say that this particular problem, and I would argue any problem, depends solely on individual activities is a mistake. That tends to be one philosophy of what makes people sick. So some people will say, well, you have high blood pressure because you're overweight. They don't try to explain, well, why do African Americans have such greater rates of high blood pressure than white Americans? Or here's another example with high blood pressure. If you live in rural Nigeria, a small village in Nigeria, there'll be a certain level, let's say 10%, I don't know what it is, of the people will have high blood pressure. If you move to Lagos, big city, the percent of people at high blood pressure goes up. Same people, same diet, same culture. If Nigerians move to the United States, the rate of high blood pressure goes up again. So clearly more is going on than simply your diet. And so this is what we think in public health helps explain a huge portion of human wellness and illness. And we call these eco-social models. I won't spend a lot of time on it, but over there on the right is what happens. How many people fall out of windows, how many people have heart attacks, how many people get breast cancer. These are all of our health outcomes. This little blue box, we're going to look at it in detail in a minute, are what we call the social determinants of health. And here, I think those of us that work in community health and public health are used to talking about this. But I think the important thing to remember is that the social determinants are intermediary determinants. They're not the root causes. The root causes are here in sort of the orange and yellow, the structural determinants of health. So that it depends on many things, including what class are you in? Trust me, if you were a Mexican-American kid and your parents were upper middle class, you would be not opening windows for coolness. You'd have air conditioning in the summertime in Chicago. How much power the group has, how much racism exists in the country, what gender they are, what education level. So these are the categories around which we structure resources in the United States. And so you expect people with fewer resources then to have bigger problems. People with more resources, as I mentioned, for example, with the fall, will have more air conditioning. And then these other issues, these fundamental issues that we don't frequently think of as being related to health. What kind of government do we have? What's the voting rights that exist in a country? What kind of macroeconomic policies. For example, with flu every year in this country, between 35 and 50,000 people die every year from flu. We don't have mandatory paid sick days. We tell people stay at home, don't come to work and infect your colleagues. But if you don't have a paid sick day and you stay at home, you may not be able to pay your rent. So that economic policy makes a difference. When COVID started in the United States, many people lost their jobs. It created major problems in communities. People couldn't put food on their table. I have a niece that lives in Berlin, and I was talking to her a year ago, and she said, well, here, the Germans just went home. They get paid 90% of their income right away. So when Germany made a decision, we need you to stay home and we need you to shut down, they sent checks to their people, not $400 checks or $600 checks. They sent their regular pay 90% to people. So those policies make a difference. Do you go into debt to go to college? Or do you have college tuition free, like they do in France and Germany? What kind of cultural values exist? We value individualism in this country, and we're at loggerheads about who should be able to walk around with a gun. So all of these things together influence health. Here we can look at the sort of expanded social determinants, and we know what these are. Do you have health insurance or not? Do you have transportation to make it to the doctor? Do you have support for behavioral health problems? There's a whole range of, do you have a decent education system? There are a whole range of things in the social determinants of health. Here's another way to look at it, and this I like this way. It's not in opposition to the WHO model that we just saw. This is from Nancy Krieger, and what she says is, look, there are three big issues in the United States: racial and ethnic injustice, racism in other words, class injustice. Are you given things in an equitable fashion based on what social class you're in? We tend so when we are giving vaccinations out in a hospital, do we just vaccinate the doctors and nurses, or do we remember that the janitors are going in there too and make sure we vaccinate the janitors? And then gender and sexual injustice. So these are the big three. There are others, religion, there are many others, but these are the big three. And that these things have an impact over a whole life course that she's showing there on the bottom. And we have to think of these not only at the individual level, but at the regional, national, and international level. So we heard some definitions before, and I want to make a clear statement about this. Only Americans talk about historically health disparities, and unfortunately, some people still do that. And I really am more interested in health inequities. So let me be clear, disparity is just a difference. So for example, only people who are biologically born as men get prostate cancer because women don't have prostates. Now that's a disparity. So if you look at what's the rate of prostate cancer among men, and then what's the rate of prostate cancer among women, it's going to be a huge difference. Is that difference, that disparity, is that an inequity? I think not. So just because you have two quantities that are not equal doesn't mean automatically it's an inequity. Here's Margaret Whitehead's definition of health inequity. I think it's there are longer definitions, fancier definitions, but this is something that I feel like my grandmother could understand. Health inequities are differences in health status that are unnecessary, avoidable, and considered unfair and unjust. So the fact that I don't have a prostate is not avoidable. Okay, but unnecessary and avoidable that we can actually do something about, and unfair and unjust. That means that there's a value system there, and you have to be clear what your value system is. Here's one way to think about it. Work with me just for the moment. The items on the left are factually true, but the real question is, what are our ethical judgments? So poor people in this country die younger than rich people. That's just a fact. The question is, should poor people die younger than rich people? Poor babies, low social class infants have lower birth weight, which is a bad thing for babies. And so the question is, again, should that be a fact? Smokers get more lung cancer than non-smokers. Should smokers get more cancer than non-smokers? and women live longer than men. And the question is, should women live longer than men? Now, if we were together in person, we could have a discussion about this. But let me just say that usually in classes like this, where people are concerned about people and health, the first 2 points, everybody says, oh no, poor babies should not die just because they're poor. Okay. People have trouble with the smokers because, again, we're taught that cigarette smoking causes lung cancer, which it does. It's one of a number of things that causes lung cancer. And so this question of should, some people have trouble with that. I will tell you, just you can have your own opinion, but I will tell you, having taken care of people for decades and taking care of many patients who are addicted to various substances, heroin, cocaine, tobacco, that my addicts always would tell me nothing was harder than quitting smoking. It is one of the most addictive substances known to man. And if I also tell you that most smokers in this country become hooked when they're adolescents, long before their brains are mature, it's like we trap our babies into smoking, you might have a different attitude about smoking. And then should women live longer than men? This doesn't worry me too much being a woman, but more importantly, we don't know why women live longer than men. So we don't know if it's avoidable. So we can't answer that question yet. The point I'm trying to make is health inequities are not easy. They're nuanced and they're controversial. And so when you see a difference, you should ask yourself, why does this difference exist? Is this difference fair or unfair? All right, see, hold on a second here. Let me go back. I skipped a, I was gonna show you a picture, but I guess, let me double check. Oh, it really did. I'm sorry. Oh, there it is. I'm sorry. I was trying to point out this picture here and I forgot that I had already shown it. This is a graph. You may have seen it before. It's something we use where we try to talk about the difference between equality and equity. Here you can see the kids are trying to look at a baseball game and they all have an equal box, but the shorty here is still short and he can't see over the fence. And so when we talk about equity, we're trying to talk about outcomes that we want. So in order for all three people to see the baseball game, the shortest person needs two boxes. This is the reality that we have in the real world. Some people are in skyboxes and some people are in a ditch. And of course, people have said, why do we have to have a fence at all? Which is always a good thing. But this is the picture I wanted to talk about. Here's another important subtle difference in how we think about things. In that picture of the baseball game, you could mistakenly think that something's wrong with this person in this purple shirt because they're short. In other words, you could think the problem is that this guy is short. Is that really a problem? Is there something wrong with being short? We don't know how old he is. Maybe he's 3 and he's going to grow. Or maybe he's grown and he's short. We don't understand. We don't know that. So there's a tendency for us to blame the person that we see as different. And that's really not what's going on with health equities. Here, this picture is drawn deliberately to force people to think. In this picture, I'm going to tell you, all 3 of these characters are exactly the same height. And this is describing a reality that exists in our country. Some people are given a box and they see over the fence, they don't have any problem enjoying the baseball game. Some people start off in a ditch, so they have to first get out of the ditch and then find a box to see over it. And some people, as this picture is showing, are actually totally oppressed and in balls and chains. The point is that innate differences in human beings is not what we're talking about when we're talking about health equity. We're talking about what can we do to allow people to be as healthy as possible, and how can we make sure that that happens? Any of you that are taking any biology, you can go and look this up. Google Rudolf Virchow. He's considered the father of molecular biology. But he pointed out that the disease of the populace is always traceable to defects in society. And certainly with COVID, we've seen that. So a problem that may seem small when you have a hurricane, a flood, a pandemic, those problems get worse. So let's look at the different things according to our eco-social model of what makes people healthy or sick. And so let's think about class. in general, and certainly in the United States, when we talk about class, we're talking about some economic status. Income is an easy thing to point to, but it's not exactly just income. Um, Most of you, if you're students now, probably have a relatively small income. Hopefully, all of you, once you stop being students, your income will improve. In our country, people tend to have more income as they get older, but this changes. The education, and we like to think education and income are related. They're not as related as we think, but educational status obviously makes a difference in terms of class. So think about religious people who take a vow of poverty or near poverty. They usually have high status in a community, even though they may not have that much money, because they serve as religious leaders. On the other hand, in most communities, people that are gaining their income by illegal activities still usually, they may have a lot of money relative to the rest of the community, but they still have low status because of how they do it. So what occupation you have and how your occupation is viewed is important. Nurses do most of the work in medicine in our country. They get paid less than doctors and they have less status than doctors, even though they do most of the work. So again, different occupations have different status. And the other thing that we don't talk a lot about when we'll look at some graphs is wealth. I grew up in the projects in Cleveland, Ohio. I'm a physician, but it's very different. I'm the only physician in my family. It's very different than many of my colleagues whose fathers and grandfathers were physicians, whose uncles and aunts were physicians and lawyers. So wealth is a different issue. It's how much money you have after you subtract your debts. So let's look at median weekly earnings. These are people that are working full time that are over 16, and you can see this is spread out by race and gender. And one thing I will point out with all of these kind of graphs is you have to learn how to look at these numbers and ask questions. So one of the things which is absolutely true, that women in general earn less than white men. We talk about that wage gap, but look here, white women, this is 82 cents an hour as the median weekly, but that's more than Black men or Latinx men, and obviously than Black women or Latinx women. So again, you have to really look at the data more carefully and ask yourself what's going on. So yes, even though white women are underpaid relative to white men, they make more money than men of color. This is looking at wealth, not income, now wealth, since 1983. And again, this is just pointing out that for Blacks, the median wealth decreased by 75%. For Latinx, it decreased by 50%. For whites, even though we had a recession during this time period, wealth increased by 14% for whites. So again, a racial difference. This is again another way to look at it. This is looking at wealth based on 2016 data. And on this slide here on the left are people who are heads of household with no bachelor's degree. And you can see that the wealth for whites. And notice that they have more wealth than Blacks and Latinx that do have a bachelor's degree or higher. So again, there's something else going on here than simply education. This is just looking at gaps, which is a major cause. The increasing inequity in wealth and ability for people just to make it from week to week is very disturbing. It causes tension and I think damages people's health. But this is looking at the gaps with the poorest 20%, the true middle class, the middle quintile 20%, and the richest 20%. Just differences in annual income. So, and this is $2011, but most Americans, their wealth is tied up in their house. If you subtract home equity out of the equation, then this is the median wealth, and that's the middle value. So for whites, the median wealth is $33,000. This is in 2011, which means half the people have more than that and half have less. For Asian, you can see it's 30,000. For African Americans, 2,200, and for Latinx, barely 4,000. So these gaps are important. And this is just, again, controlling for education. Even if you control for education, there's still differences. So class operates in this country. It's operating every day. And we'll talk in a minute about there are major class differences in health outcomes. What about the role of segregation and structural racism? Again, let me do a quick commercial here. This is from the Legacy Museum in Montgomery, Alabama. This happens to be the lynching memorial. If you ever have a chance, if you're ever near Montgomery, take a day and visit this museum and memorial. You won't regret it. So let's talk about racism. In my definition of racism, racism and capitalism are linked. They grew up together, they're intertwined. And racism is a hierarchical system. That means you have people on different rungs of a ladder that unfairly disadvantages some people, people of color, unfairly advantages some people, and more importantly, saps the strength of the whole society. So if we keep this definition of racism clearly in mind, racism exists as a system to support white supremacy. It's not an individual level attitude. Now, I'm not saying that some individuals don't have bad attitudes. Okay, I'm not arguing that. What I'm saying is it's a system, and you could be the greatest person in the world, but if you're entrenched in a system based on racism, which is what we have in this country, whether you want to or not, you get advantages or disadvantages from that system. In the world scene, anti-Black racism plays a special role, and generally in the world, Africans occupy the bottom rank. But this is equally true, and I hope, unfortunately, in the past 2 weeks, it's become more obvious. It's not binary. Racism is not a binary. It's not just Black people and white people. Rankings of color exist in a hierarchy, and that's why we've seen such horrible anti-Asian racism of late in the public eye. And then capitalism. This is a quote from W.E.B. Du Bois, one of our finest social scientists of the last century. And in his book, Black Reconstruction, he argues that Black labor, that the stealing of land first from indigenous people in the Western Hemisphere, but all over the world, colonialization, and Black labor and other labor is really the structure on which European wealth, the United States, European wealth was built. And you can't ignore that. And I will also say, for those of you interested in healthcare, though I'm not going to talk too much about it today, maybe we can talk about it during the questions and answers, that American medicine played a special role in promoting and endorsing what they call scientific racism. So we have a special role as physicians in the world in terms of the contributions we made there. So race and class exist. Class, SES, social economic strata, is a major contributor to disparities in health, but race still matters, and they often operate independent of each other. So if we're going to address differences in health status, we have to be willing to look at the broad determinants of health. So let's look at some examples. And again, I'm not going to spend a lot of time. It's just I have throughout this lecture some books. You can get the PDF and look them up. I just want to point out that this history, Indigenous Peoples' History of the United States, is an excellent overview, a high-level overview of the history in North America. It's useful looking at. And Paul Ortiz's book, again, reframes early history, looking at Black and Latinx collaboration and cooperation about history. So we know, of course, that Europeans came, and certainly the history of Native Americans and their health is important. This is trying to talk about the impact of smallpox on Native American populations, and really almost wiped out some of these populations in local settings. But what I want to say is that this impact that happened during first contact is still happening today with COVID, as we'll see in a little while. And so understanding the history of this country, this is a graphic of the Trail of Tears and the efforts to kill off Native Americans. Native Americans are still here, and they're doing strong, and they're fighting back, so they didn't all disappear. But this is one community which we have, the United States government by treaty is supposed to be responsible for health. Not that we do a good job at it. And here's a view that I always try to convince my grandchildren is important. This is just a graph of where Blacks have been in the United States of America. 60% of our time were spent enslaved. And then another century in quote Reconstruction and Jim Crow era. And maybe if you post civil rights from 1965 to now, it's only 14%. Let me put it to you this way. Slavery was not a long time ago. Why do I say that? I'm 72 years old. When I was a little girl, I remember being introduced to old Black people and being told, Sister Annie or whoever it was, they used to be a slave. I remember meeting people. I remember people who had been enslaved holding my hand, holding me on their lap. That's not something that my grandchildren can say. But just think about that. I'm here still alive and breathing, and I actually physically met people who were enslaved. It is not that long ago, unfortunately. The other thing I'll say is that we too often don't read our history well. We don't pay attention to our history. This is just a map of the transatlantic slave trade. So at least 20 million Africans were taken from the continent and enslaved in the Western Hemisphere. This is something, this isn't news, but we don't teach it well enough. Only less than 400,000, you can see here, less than 400,000 slaves ended up in the United States. The rest of the slaves, so that means 95% of the slaves that came over from Africa ended up outside of the United States in all these other places, in the Caribbean, in Mexico, in Brazil, especially, all over the hemisphere. So most African Americans, that is to say, most people of African descent with a slave heritage live outside of the United States, and they speak Spanish and Portuguese. Think about that when we think about what we mean when we say people of color. Some more great books for you, Black Reconstruction. If you want to understand what happened in January 6th, go back and read Black Reconstruction. That's a different lecture, so I'll just say that. I'll tell you this, when President Trump was elected, I immediately said I have to reread these two books, Black Reconstruction and Nell Painter's History of White People. Don't think you can understand racism by only learning about what happened to Native Americans or what happens to Chinese. You have to understand the history of white people, and Nell Painter's book is a great book to do that. So you all know this. This is Texas history here. You have to really think who's an immigrant. What does that really mean? When Mexico lost the northern half of their country in a war, what really happened? What was supposed to happen, according to the treaty in 1848, is that Mexicans who were north of the border were all automatically to become American citizens. That's what the treaty said, but we're not very good at this. So most people in this country know something about the lynching of Black people in the South after the Civil War, as Jim Crow reared its head and as the Klan, as white terrorists run amok through the South. And this resulted in huge migrations. 6 to 8 million people, Blacks, fled the South, fleeing north and west. But at the same time that we were being lynched in the South, Mexican Americans were being lynched in the Southwest. And not only that, that's that picture there, not only that, they were lynched in the same decades as the Klan was doing its work in the South, and more or less at the same rate of lynching. So this was a huge impact on that population, something that usually is not taught. And so when I see these pictures of ICE detention situations, I actually don't think of it as some kind of weird invasion from the South. I actually remember this picture of people being lynched. And I know what happens when your family is threatened, when gangs have taken over, when you have terrorism at your home, you flee. And if you can't flee completely, you try to get your children out. So I think of Black people sneaking on a train leaving Mississippi and coming to Cleveland or Chicago or Detroit. That's what I think of. And think about the impact on those families as they had to send their young people off to try to escape that kind of terrorism. We have had this horrible Asian racism rear its ugly head again, but this is not new. Um, this happens to be pointing out the anti-Asian remarks that led to the Chinese Exclusion Act of 1882, which was not rectified until the 50s. So even though Chinese laborers were brought here for gold mining and to build Transcontinental Railroad, this act, really it restricted them from immigrating. There was an act before that, the Page Act, that restricted the immigration of women, Asian women. Actually, the largest mass lynching in the history of the United States was done by 500 white men rampaging through a Chinese community in Los Angeles in 1871. And they lynched at least 20 Chinese men and boys and killed many more without lynching. So this history of anti-Asian racism is embedded in the country and is part and parcel of the United States. I want to also, we have to remember the creation of concentration camps during World War II and the internment of Japanese Americans. This didn't happen to Italian Americans or German Americans. So this problem of racism goes beyond just Black people, and we have a long history of it. Here's another book that looks at anti-Asian racism that you might find helpful. And this particular graph is looking at unfavorable sentiment about Asians and China. This is specifically China in the recent period between 2005 and 2019. So you can see, starting from 2013, it really has gotten high in terms of unfavorable attitudes. So I just want to stop here just for a second so we can think about what this means in terms of our history. It's not that we don't make progress in the United States. It's that our progress has never been a simple straight line. So Native Americans were not even assumed to be human, you can see here, until 1879. Think about that. It took a trial for the Supreme Court to say, oh, well, yeah, they're really human beings. And it's really, even though in 1924 a law was passed to allow people to vote, actually, they didn't really have the real right to vote until after World War II. And you can see some of the others. So it's not until the 50s, after World War II again, that there's an act that allows people of Asian ancestry to become citizens. So we are a nation of immigrants, but we have not always been welcoming of those immigrant groups. So let's look at health a little bit in terms of that. The thing about this graph, you don't have to worry about the details, is that there's so many diseases. In this case, asthma, ADD, infections that are related to class. And so you can see here that the blue bars are the poorer groups. This is what relationship people have to poverty. Sometimes, like here with hay fever, it goes in the opposite direction. But really, the situation where poor people have more high blood pressure or poor people have more asthma, more diabetes, that social gradient, it tends to be the typical one that we see. Here's another thing where we've age adjusted the death rates. These are death rates for specific diseases. This little caret, this upward arrow means it's statistically significant. But you can see here for the big three, diabetes, heart disease, and cancer, all of these groups have statistically significant higher death rates than white Americans. And again, this is just looking at some examples. There are lots of examples, but examples we don't always talk about. This happens to be Native Americans and Alaskan Natives that have higher death rates from kidney cancer. And this, again, it's the same group looking at liver and bile duct cancer. So you have to look in carefully. And I will say this, with the Asian Pacific Islanders, we don't know what that is because we don't break that data down, but that's a different problem. So we talked about racial discrimination. We talked about class discrimination. What about gender? And here I mean gender speaking broadly. So there are differences based on gender that we can't explain, based on different power arrangements with gender. Black men and Native American men in general. If you just picked a disease and asked me who had the worst situation, if I say Black or Indian, I'll probably be right most of the time. So this is just pointing out, this happens to be for heart disease and stroke, that Black men have the highest rate, followed by Native American men. Not unusual. Let's look at some female related things. This is maternal mortality. What's the chance of dying around pregnancy? The definitions changed a little bit over time. But again, this is comparing the United States, 26.4, with all of these other rich countries in 2015. Pay attention, all these other countries are below 10 per 100,000. That's what they're below. But these are all these other nations. Now, let me just say, over the past 100 years, the number of women who die in childbirth or around pregnancy, not just in childbirth, but around pregnancy, has been steadily going down in these rich countries in the world, except for the United States, where it started going up. Here's another look at it. And if you look at this little graph on the right, this is just looking more carefully from 87 to 2013 at the pregnancy-related mortality by year. This is for everybody in the United States. But notice for white women in this period, 2011 to 2013, is 12.1 deaths. That's higher than all those rich countries which were below 10. So even if you ignore people of color and you just look at white women are doing worse than their peer countries. For Black women, the maternal mortality rate is 40. And then they lumped everybody else together here at 16. But here's a really Native American woman to have it the second worst over here on the left. So again, pregnancy related, that's 41 for Black women, 30 for Native American women. Here's infant mortality, something we studied very carefully in healthcare for many generations. And again, we can break it down by race and ethnicity. This picture is always depressing to me. Let me try to explain it to you, which I think you would agree. Here on this graph, the lower you are, the better you are. So here, this green line, those are white women that have had at least some college. And if I had a picture for college graduates to be able to, so that means you don't have very many babies dying within the first year. And so here we can see the green line, those are white women with the college, some college education. The red line is white high school dropouts. So you can see that they have more deaths in their babies than white women who have gone to college. This is a depressing part. I don't know what color this is, pink. This next line up from white high school dropouts are Black women who have gone to college. Our birth outcomes are worse than white high school dropouts. They're better than Black high school dropouts, but they're worse than white high school dropouts. And the kinds of things that we normally associate with good birth outcomes, being well educated, having a healthy diet, being able to go to get medical care, these are all true. Black college graduates have all of that compared to white high school dropouts. Why are our birth outcomes so much worse? This is another look at infant mortality. Don't worry about the details or the year. This is to point out that when you lump people together, in this case, if you lump Latinx together, you get one thing, but when you break out groups, you get a different picture. So Puerto Rican infant mortality approaches that of Blacks. On the other hand, Cuban infant mortality usually is around that of whites. Same thing here for Asian, even though we haven't broken it out. Trust me that the rate infant mortality for Japanese, I'm going to suggest is probably going to be better than the infant mortality for Vietnamese. But if we don't study it, if we don't break it out, then those problems stay hidden. Here's another disturbing question. It's a fact, and ask yourself why this happens. If you are born in Mexico, but you came to the United States, and in general, those women who are born in Mexico who came to the United States in this recent time period usually have less formal education. Their command of English may be less. They are less likely to have medical insurance. But if they live here for less than 7 years, their babies are pretty healthy. They're great. If they are born in Mexico and they live here longer than 5 years, then they have poorer, sicker babies, smaller babies, sicker babies. And their daughters who are born in the United States, who have command of English, generally have better education, have higher rates of medical insurance, they have worse birth outcomes than their mothers, and their granddaughters worse still. Something happens to babies when the parents stay in the United States. Think about why that might be, what's going on here. Here's another disease to look at. This happens to be breast cancer. Some of this we could understand. This is stage 1 breast cancer, means it's early, and if we catch you in stage 1, our chances of curing you are pretty high. Stage 4 means it's spread already. So we want to catch it early. That's the whole point behind mammograms. So what this is showing is that, for example, Blacks, a smaller percentage are found in stage 1. So for Blacks and Latinx and people of color, they're more likely to have their breast cancer diagnosed at a later stage, which means their chances of surviving are worse. That's not surprising when you consider money, resources, health insurance, and the like. But here's some other things. This happens to be Chicago data. Look here in 81. If I went back, I could go back into the 70s and 50s. The actual rate at which people died, the mortality rate in Chicago for Black women and white women, was basically the same for decades. It was the same. And then here in the 90s, you begin to see a separation. So you begin to see that Blacks start dying at higher rates than white women. And so when you see something like this, you should say, well, what's going on? What happened? Well, breast cancer didn't change. What happened here is that our ability medically to cure breast cancer or to effectively treat breast cancer improves. Our mammograms get better. The chemotherapy that we have gets better, and we're better able to take care of this cancer. And so what's really going on here with white women is, as we get better medically to take care of them, their death rate starts going down. That makes sense. But unfortunately, when you consider racism, class, income, and all these other kinds of things, Black women are not able to take advantage of those technical changes. And so their death rate, it's hard to see here, but if you look, their death rate pretty much remains unchanged. It stays in the same neighborhood. So sometimes you can have a situation where you don't have a disparity. So in 1970, there was no disparity between breast cancer death rate. Black women and white women died from breast cancer at basically the same rates. But again, if you have some new advances and you're able to put it in one place, that's what happens. We can see the same kind of thing for cervical cancer, where it varies by race and groups. So race and class are all important. Now, I am a physician, so I do want to say, I want people not to smoke. I want you to exercise. I want you to eat healthy, but understand what's really going on. So this is a change in price. Fruits and vegetables have gotten more expensive since 1985. And dairy products, red meat, poultry, you see all the sugar, these are all the things that have gotten cheaper. Okay. And so if you don't have a lot of money, you're better off buying hot dogs for your kids than fruits and vegetables. So you have to think about a whole system, a whole food system. You can't just think about one little thing or whether people know how to shop. This is a model, chronic care model. In the United States, chronic disease is our biggest challenge. But I just want to get, this happens to be one of our health centers in Chicago, and here's some historical pictures from health centers in Mississippi. So having health centers are important. They're in the community, they're in poor communities. They take care of huge numbers of people that wouldn't have healthcare without them. In 2010, some 20 million people. It provides a big portion of primary care for low-income people. This is one of our clinics in Chicago, where we had people with our staff, doctors, nurses, clerks, that we do a walking club on Saturdays and promote good health. But in this particular neighborhood, they didn't have grocery stores. And so one of the things that this clinic did with our staff and other people from the nursing school and our nutrition is to work with the local stores and change the kind of stuff they had in the stores. So lifestyle is important, but on a population level, it's not as nearly as important as you think. I hope many of you are planning to go into health careers. This is looking at how many men and women are in medical school in 2018 by group. You can see here for Blacks that Women outnumber the men. Blacks only make up about 5% of doctors in this country, much fewer than we are the population. This to me is really a sad comment. Let me take a minute here and talk about that. When I when I retired from the hospital in 2014, that year 515 Black men started medical school. When I finished my internship at Cook County Hospital in 1978, 542 Black men started medical school. So there were more Black men starting medical school at the beginning of my career than at the end of my career. This is a major problem. We need people of all types to go into nursing, medicine, and all of these other things. I want to just take a minute with COVID, and so we can end up. You've seen these rates. This happens to be national rates from February. And you can see here, Native Hawaiian, something we don't usually talk about, had the most cases per 100,000 people, then Native American, Latino, Black. These are national numbers. Here are the deaths, okay, per 100,000. Here are just death rates per, some of these are age adjusted and some of them are not. This is another way to look at it. So Blacks are 2 times more likely to die than whites, for example. And again, with Asians, you have to be very careful. I happen to know in the Bay Area that Chinese Americans had the highest death rates. And if you understand the Bay Area and who works there, you would understand that. So is the problem with COVID that Blacks have more high blood pressure or Mexican Americans have more diabetes? Both of those facts are true. This, whether you have high blood pressure or whether you're an asthmatic, for me as a doctor, will impact what I do with you and how I treat you. But the real reason we saw these differences by population are these structural determinants. Who's allowed to work at home and who isn't? Okay. If you work at home, you have to have a certain kind of job. If you're a receptionist, there's no work you can do at home as a receptionist. What kind of community do you live in? Do you have a grocery store in the community? What kind of housing do you have? You know, when Oprah's boyfriend got sick, she put him in the pool house. Well, most people I know, you're lucky if you have enough bedrooms for folks. So what kind of housing you have available to you? Where are your populations? Congregate settings, people that are in jails and ICE detention centers, people in nursing homes, people in dorms, military barracks. These are places where infectious diseases spread easily. People that had to go to work, people that were unhoused, obviously, people that don't have medical insurance. This is how most people that I know that had to work. You might be afraid to go to work, especially early in the pandemic. There wasn't enough PPE for people in hospitals, much less everywhere else. But if you didn't go to work, you would basically be starving to death. So these community structural things, what kind of pollution, what kind of walkability, is there a food desert? These are all things that impact what neighborhoods had high rates of COVID. And the last thing I want to say, because even though I'm an urban person, let me just put this through you. The blue areas are counties with ICU beds, at least one. Okay, it doesn't tell you how many. The orange areas are counties with no ICU beds, and the gray counties are counties with no hospitals. So to think that we're all equally able to survive this kind of pandemic is crazy. Look at Texas. Look how much of Texas here is orange and gray. Some more books. I won't spend time on them. Please look them up later if you're interested in Black health. And if you're interested in Latin American and Asian and other things, Native American, here's some more books that will do well. So what about solutions? This is what the WHO suggests, that you have to pay attention to the living conditions. You have to think about how resources are distributed, and you have to keep track of the problems. So I'm not going to read all of this. You have to, we know what we're supposed to do. We know what we're supposed to do from social science. We know what we're supposed to do for social work. We have to have policies that support young children. That means they have to be able to eat. They have to have good health care. We have to have education that's equal and excellent. We don't have that in the country. We have to have employment and working conditions that are safe and protected. And we have to have good policies for unemployment. I had the privilege of practicing in Canada for several years. If you become unemployed in Canada, you don't lose your health insurance, because your health insurance is a national program that is there whether you're employed or not. We have to have housing policies, rent control, what kind of income distribution we have. We have to have policies that deliberately dismantle racism, anti-racist policies in all of our institutions. Um, I know that I'm not politically naive, okay, but I will tell you this: the fact that we do not provide universal medical insurance for everyone in the borders of the United States is a shame. It causes me, I can't tell you how much distress it causes me. This is a basic human right, and this is something that we could have done in the first 100 days. We could have passed Medicare for all. We need to have a single payer system. It's a basic, simple reform. We're the only country left, the rich country in the world, that doesn't have some kind of universal medical care guarantee. Um, so think about these issues when you think about what causes disease. So here's some conservative estimates that low education causes 245,000 deaths. Well, heart disease just kills 659,000 people in the country. Cancer, 600,000. You can see accident. Those are the big two. And after that, you're below 200,000 with all of these other things: stroke, diabetes, kidney problems, flu, suicide. All of those are much less than low social support, racial segregation, individual level poverty. So when you really look at the causes for the diseases, if we had this more broad approach, we could put in policies that would make a bigger difference in people's lives. Let me end with a quote from Dr. King, one of my favorite quotes, which actually matches Brother Malcolm's quote at the beginning, where he said, "Thinking is dangerous." And Dr. King points out that rarely do we find men who are willing to engage in hard, solid thinking. There's an almost universal quest for easy answers and half-baked solutions. Nothing pains some people more than having to think. Um, I want to encourage all of you students here. We have so many things in this country that we have left to do. We need your youth, your energy, and your thinking to help us get out of the mess we've created and make a world that we can be proud to raise your grandchildren in. So let me stop here, and I look forward to discussing things with you.
Thank you so much, Dr. Murray. It's been wonderful to have you here and have you tie all of these things together for us. We've got lots of different people here with us today, from the community, from Baylor, from the medical profession, students, just the whole gamut. And I want to welcome my partner, Dr. Stephanie Body. She and I work together to teach this new class on disrupting racial disparities in healthcare. And Dr. Body is a PhD with the School of Social Policy and Practice. That's where she got her education at the University of Pennsylvania. And she's here now in the School of Social Work, the Diana Garland School of Social Work, together with the seminary, together with the School of Education. And we're delighted to have you with us. I want to encourage our audience to post questions for you. And we're really willing and eager and ready to take your questions. And I would just like to start, Dr. Murray. You know what it's like to be a busy practitioner. You know what it's like to be seeing patients in the clinic. And the thought of that kind of life, busy seeing patients, and then also finding a way to really have an impact in the public realm. What would be your best advice? What would be the best way for busy clinicians to engage with some of the changes that you are saying need to happen?
Well, I think it helps if you take our blinders off and think more broadly. So look at that example I gave from one of our health centers. So there you had a whole range of busy health workers, nurses, clerks, physicians. But when they thought about the things that were making their patients sick, food deserts was one of the things. Now, they didn't have time to go set up a grocery store. But what they did is they worked with their patients. They didn't have a separation between our physicians and patients. And so they didn't all, we share Saturdays. So the Saturdays they weren't seeing patients, they were willing to go on a walking group with their patients. So in that process of just working where you are, then that walking group said, well, what can we do about the grocery stores? And so they were able to bring in help from our College of Nutrition and from our nursing school to have a program with these corner stores and really improve the kind of fruits and vegetables. That's one way. If you're a nurse and you have young children, you care about your children, maybe your work beyond taking blood pressures would be what's going on in my local school. What's my PTA doing? Okay. Many people I know are active in their church or mosque. Again, you can incorporate that. So to me, what you work on really depends on what else you're doing. So I've worked in healthcare because I'm a physician. I have colleagues who are teaching. They tend to work in the area of education. But when you start with a problem, whether it's why can't my kids read or how come I can't get a textbook in my classroom, and you keep asking that question of why, what is the structure that's forcing what we can do, then you can gather other people and work on that structure. So I don't think you have to work on the same thing for your whole life. And I don't think, I think it can vary, and there are plenty of people. Now, the last thing I'll say will sound a little, this is what is in my mind. My great grandmother spent time with us when she was still alive, when I was a child. She was born during Reconstruction. And this is what she told me. As all of our grandmothers tell us, she said, Linda, white people are going to knock you down. They're going to always knock you down. And the only thing that you have to decide in life is how often you stand up. And so for me, at least, I didn't think I had a choice. Either you stay on the ground and let people trample over you, or you stand up. And so I think that most people in this country want to stand up. If they don't want to stand up for themselves, they want to stand up for their children and their grandchildren. And if you keep that in mind, then you can do stuff.
Thank you for that. Dr. Body?
Yes. Our next question is, what can you tell us to help us in Texas to advocate for universal health care without triggering the false or uninformed claims of communism or socialism that are red herrings that allow people to avoid tackling the real reasons for supporting universal health care? What is your thought about that?
So I will say this, and certainly when I was younger, the problem or the scariness of communism was much worse than it is today. So let me just say that. But we have to be willing to engage in honest disagreements and conversations. So we can't shut up because someone's going to accuse us of being a communist. We can't shut up because they're going to say something bad about us. We have to be willing at least to have the discussion, or if you will, even the argument. So if you care about medical policy, then there are like I said, every country but ours, every rich country but ours has some universal health system. I had an opportunity to practice in Canada for several years. The Canadians don't think that their medical system is communist. Some people in Texas might. So I think it means being knowledgeable about the policies and helping people understand. For example, with COVID, we want to make sure that people keep track of these infectious diseases when they come about. We want to make sure that people are vaccinated in a rational way when you have a problem like this. So I think it means learning more about Medicare for all. And you don't have to, that's what I support. If you want to support something else, that's fine. But we can't even have an argument about it if you don't become knowledgeable about what's going on. I had an opportunity, like I said, as an American physician to practice medicine in Canada. While there are a few Canadian doctors that try to come to the United States, most of them would not trade their Medicare for all system for anything. Most Canadians would not trade it for anything. And so I think most physicians in the United States, when we've done surveys, they actually support Medicare for all. They may not believe other people do, but they actually do support it. It frees you up. It allows you to practice our craft in a humane way and not be worried about whether the patient can afford the prescription you've written or whether the patient can afford the x-ray that you've ordered. So to me, it's basic human rights.
We have another question, Dr. Murray. Where do you think the main resistance to the single payer system is? Is it insurance companies? You just mentioned it doesn't seem to be physicians. So where's that main resistance coming from?
I do think it's insurance companies. They're at risk. And so let me be honest. Right now, we pay the insurance companies billions of dollars in profit to move money around. If we had a single payer system, one of the savings would be we would get rid of that system. We wouldn't need all those insurance companies. But I also think it's political. I do think big pharma and our big insurance companies are against it. There are many Americans who think that we couldn't do that in the United States. That's sort of you defeat yourself before you even get started. But the real issue is, where's the political will? So I would say, frankly, that as Americans, we do not have a very democratic country. There's so many things that most Americans support by all the polls. And when you look at single payer, no matter how crudely you put the question, most Americans support that. They do not think a child should die because they don't have medical insurance. Okay. So we have to learn how to use the levers of democracy to get what people in this country want. If we're able to do that, a lot of the tensions we feel, the interracial tensions, the interethnic tensions, the immigrant, non-immigrant tensions would fade away if we were able to actually take the resources of this country and do with them what most people, they want to have a meaningful work. They want to have a safe home, a comfortable community. They want to enjoy their family and their neighbors. That's what most of us want. And there's absolutely no reason why we can't do that. We have to be willing and brave enough to work together to make sure that happens.
Okay, thank you. Well, our next question, this audience member would first like to thank you for the wisdom that you share with us today, and would like you to say more about how health outcomes are less about genetics and lifestyle and more about the structural inequalities.
Right. So let me try to address these. Now, genetics and lifestyle are not unimportant. So okay, so you, in complicated situations, you have lots of things going on. So as a physician, I spent hours working with somebody to help them quit smoking. So I'm not suggesting that genetics, much less than anything else, and lifestyle don't have major impact on people's health as individuals. But in terms of what happens to large groups of people, these structural factors are far more important. That's the consensus of many of us in the public health arena. It doesn't, so it's not a contest like either this or that. You have to work on both ends of the circle. So just for some things that I learned in my life. So there was a time when actually, when I went to college, they were still handing out cigarettes freely on the airplanes, for example. Well, that stopped. We used to advertise on Saturday morning cartoons. When I was a little girl, it was advertised. So the individual level behavioral stuff is important, but if we want to make real changes, when we made a decision, we're not advertising tobacco on TV, and we're going to tax. This was a big change. We're going to tax tobacco farmers. We're not going to give them tax-free status. Then you begin to see smoking rates going down. So you have to work on both ends, on the big policy structural things, as well as individuals. If we talk about racism, we have to deal with structural racism. Does that mean we ignore individuals that are exhibiting racist behavior using the N-word? Not at all. We can say that is not acceptable to do that. But if we don't address the structural conditions that still force Black people to live in substandard housing, still have our schools not teach kids how to read, then we're not making real progress. So yes, I do believe that the eco-social model allows us to intervene in a more deliberate and successful fashion than trying to convince each individual to change their lifestyle when even if they tried to do that, if you don't have the food in your neighborhood, you can't get it.
We have a question from one of our students about how to stay informed, because things are changing so rapidly in an ever-changing society. She says, how do we knowledgeably filter the information that we get by media and outside sources? How can we, as college students, gain a deeper understanding of the inequalities in the world outside of the classroom?
So, I think this means curating where you're getting your information from. So, for health, if you're interested in health, there's certain organizations, there's certain websites, there's certain podcasts that give reliable information. And so I tend to pay attention to those more than other things that I never heard of before. I may investigate to see what I think of them. The second thing, though, doesn't change. Go to the source. So for example, if I'm reading the Chicago Tribune one morning and they say a new study has shown blah, blah, it is an area of health, an area that I'm interested in, then I go find that study and I look at it. Is this a reliable study or not? And that helps you. So if it turns out to be a piece of junk, then I might not worry what the Tribune says tomorrow, But I actually try to go and look at the information at the study. The last thing I'll say for students, and I meant this sincerely, I didn't just put those books in there for health. It's not enough if all you do is study what's in your coursework. Even in graduate school, you just read the journal articles, because journal articles very short. You have to have a broader knowledge base, and that's why and plus books are more fun to read anyway. That's why those books I listed up there, which again happen to be oriented toward health. If you were interested in education, read actual real books that take a couple of 100 pages to develop a theory or develop a thought, and then you can ask yourself, does this make sense? Did they prove their point? So for students especially, read books outside of your class, read books, and then always try to double check your sources. Go to the original source, and so that you have an idea. Don't just depend on secondary people telling you this study said this study said that. That would be my big advice for students.
We've got a lot of questions that we're not going to be able to get to all of them, and I apologize for that, but I'd like to pose this last one in the few minutes we have. This is from a colleague of mine at the Waco Family Medicine, Dr. Webb, who says, thank you so much for this talk. It's been incredibly valuable. He wants to know, in addition to building pipelines that are changing policies that lead to inequity in medical school recruiting, what do you think are the most important changes we could make to medical school and residency education to begin emphasizing health equity?
Well, so I have a couple of quick things for that. I'm so glad, Dr. Webb, you asked that question. First is, what do we think is important? So obviously, this is something we don't all agree on, but I think all of us that are in practice know that just because you can recite the Krebs cycle and other biochemical pathways doesn't mean you can talk to a patient. So we need to make sure that our pre-med students and pre-health students learn other skills sets, and that means we have to value information and knowledge in social sciences and in history, etc. That's the first. So the prerequisites that we have to pay more attention to. The second thing I'm forgetting what year this is going to happen, but for those of you that aren't physicians, we have a process in terms of national board licensing exams that people start taking in medical school. At some point soon, they're going to become pass-fail. Part one, I think, is going to become pass-fail. I forget what year, but some year soon. I think that's a big, and the reason why that's important is because in the recent past, you couldn't even get interviewed for certain residencies if you didn't have a score high enough, and those exams were never meant to do that. So being clear, this kind of pass-fail notion. After all, we want physicians to have a clear level. We want them to have a minimum level of knowledge, right? A level above this you could practice, below this we don't want you practicing. That should be true in general. I would love if they did that for the MCATs. Why can't we have 3 grades for the MCATs? Ready for medical school, maybe not ready yet, we're not sure, not ready for medical school. Okay. Because that's all we care about, because we know that your MCAT score is not related to what kind of physician you become. We've done studies on that. So I think being better at measuring what's really important. And finally, if you believe in the eco-social model, that means people have to be more knowledgeable about those sciences, anthropology, political science, history. How can you analyze structure? So I'll tell you, for example, as a physician, that January 6th wasn't a surprise to me because I understand where the Electoral College comes from. And in my opinion, the Electoral College in the United States was there to support white supremacy. So if you want people to vote, if you want young people to vote, for example, and you don't understand why the Electoral College exists, you may have trouble convincing them. So I think it means a different set of skill sets. It doesn't mean an abandonment of the biomedical skill set that we presently have, but it means expanding that and being honest with each other about what we really need to practice.
Great. Well, thank you so very much, Dr. Mary, for such an enriching and informative presentation today. Perhaps we can send forward some of the questions because we did have several that we could not answer today, but we're so grateful for your deep wisdom that you bring and for this time that you've given us today. Thank you.
Thank you. I enjoyed it all.
Oh, great. Now I'm going to turn it over to Carla Batista to conclude our program today.
Hi, everyone. Yes, I would like to thank again Dr. Murray for her presentation, for the moderators, Dr. Baird and Dr. Body, for asking the questions to her, and for our participants for engaging with us in this presentation and y'all's great questions. I do want to share with you that we have two upcoming events, April 9th and April 16th, where it'll be the same format, and those the emails with registration links will be sent out. And also, I want to remind y'all that if y'all are a Baylor ID holder, y'all are able to get some discounts at local businesses. And this is another one of our programs that comes out of this office. We know that in order to support a community and to build wealth, for people who live here, we need to support local businesses, local families. And so this is another great way to support the Waco community. Once again, I would like to thank you all for being here, for joining us, and we look forward to April 9th. Thank y'all and have a great afternoon.